Around 700,000 people die every year of heart disease. To put it in perspective for you, that is 1 in 4 people dying of heart disease alone. And among them, myocardial infarction is responsible for half the deaths. So saying that this is not a common occurrence is a blatant lie. But just what is myocardial infarction? From a medical standpoint, because I like medicine, myocardial infarction falls under the umbrella of a broader clinical term, a spectrum that we call ischemic heart disease. 4 syndromes fall under this name: angina pectoris, chronic ischemic heart disease, sudden cardiac death, and none other than our unwanted little friend, myocardial infarction. What groups all of these syndromes together is that they all have a common cause: myocardial ischemia. A myocardial, something related to the muscle cells of the heart that we call myocytes, and ischemia referring to a reduced blood supply, all of this meaning reduced blood supply to the muscle cells of the heart. It is important to note that just like any other tissue, the myocytes of the heart also need a constant supply of oxygen and nutrients to function properly, which are carried by the so-called coronary arteries. This all means that the cause of ischemic heart disease, and in turn myocardial infarction, is simply put, an imbalance. The blood supply is able to carry only a fraction of what the heart actually needs to function properly and optimally. And because the heart is a muscle that is constantly active, this can have devastating effects in a really short period of time. Have you ever thought, though, why precisely is oxygen so important? There has to be a reason. And there is. Because all the energy the heart muscle needs, and that is a lot, is derived almost exclusively through a process called mitochondrial oxidative phosphorylation, which is a process that happens in the mitochondria, results in the creation of ATP, the main form of energy the cells use, and most importantly, only occurs in the presence of oxygen. Basically, what I am trying to say is no oxygen means no mitochondrial oxidative phosphorylation, means no energy, means cells can't function, means they die, through a process that we call necrosis. Now that we've established the basics, let's take a step back and return to myocardial infarction. Myocardial, something related to the muscle cells of the heart, myocytes. Infarction, an area of ischemic necrosis, cell death due to lack of oxygen, caused by the occlusion of the vascular supply to the affected area. What happens in this case is 1 or more of the coronary arteries that supply blood to the heart get occluded, clogged if you might. This results in less oxygen being carried to the heart muscle, and as a result, eventually the tissue dies. But this normally doesn't happen. So what can possibly go so wrong that it causes these arteries to clog and the heart to die? 3 main ways this could go. One of the causes is believed to be spasm of the artery wall, vasospasm, which may occur without cause, or in some cases it might be triggered by alcohol withdrawal, emotional stress, and is most commonly found to happen in people who smoke, have high cholesterol levels in blood, and have high blood pressure. The second way myocardial infarction can be caused is through what we call embolization from mural thrombi. This is a fancy term for when a thrombus, or a blood clot, that is usually formed in the left side of the heart, gets dislodged. As it flows with the blood, it enters the coronary arteries, continues to travel downstream, until eventually encountering a part of the vessel that is so narrow, it simply cannot pass through. It gets stuck there, and prevents blood from reaching parts of the tissue that are downstream of that place. These 2 causes account for 10% of myocardial infarction cases. So what happens in the rest? In 90% of the cases, the underlying cause of all of this is a disruption of a pre-existing atherosclerotic plaque, or coronary artery disease. This is atherosclerosis of the coronary arteries. Atherosclerosis is a chronic disease. It takes years to develop, and according to one hypothesis, the underlying cause is a chronic inflammation of the innermost lining of the arteries as a response to injury. All of this results in the formation of lesions that protrude in the lumen of the artery. These lesions are called atheromas, atheromatose, or atherosclerotic plaques. These raised lesions are composed of a soft, friable lipid core made up mainly of cholesterol, cholesterol esters, and necrotic debris, covered by a fibrous cap. They are the main cause of coronary, cerebral, and peripheral vascular disease resulting in heart attack, stroke, and gangrene, and are responsible for more than half the deaths in the US, more than any other disease. The beginning stages of atherosclerosis are present in virtually all the children above the age of 10. But whether those lesions will continue to develop and cause different levels of flow disturbance depends on several risk factors. Increased risk is attributed to people between the ages of 40 and 60, male or postmenopausal women with genetic metabolic disorders, hypercholesterolemia, hypertension, smoking, diabetes, inflammation, and so on. It is important to note that these factors have a multiplicative effect, meaning having 2 of them will increase your risk of myocardial infarction 4 times, but having 3 will increase it up to 7 times. Now, what is interesting is that these plaques usually stay clinically silent and do not cause chest pain or any other symptoms, even during day-to-day physical exertion. Until, that is, the plaques narrow the lumen by 70%. When surpassing the critical level of 70% up to 90%, chest pain starts occurring with different levels of exertion. And if the occlusion surpasses the 90% mark, chest pain is present even during rest. But this is assuming nothing happens to those plaques. Unfortunately, the majority of myocardial infarction cases happen when the plaques haven't even reached the critical level of 70%, so the patients most likely won't even feel that they suffer from this disease until suddenly they start having acute symptoms of a heart attack. This can be prevented, though, by having regular checkups and consulting with your doctor if you find yourself falling under any of the categories that pose an increased risk of atherosclerosis. So what happens in those cases? That is a result of a disturbance to a pre-existing atherosclerotic plaque. That disturbance can appear as erosion of the fibrous cap, rupture of the atheroma, or intraplaque hemorrhage with or without rupture. But regardless of how, what happens in the end is that the inner components of the plaque get exposed to the blood. And because they have coagulative properties and cause platelets to adhere, aggregate, and get activated, the coagulation cascade gets activated, and blood clots start to form. The clot can go on to occlude the entire lumen of the vessel, or the cascade can stop with a subtotal level of occlusion. And in that case, the thrombus organizes and we get what's called an atherothrombosis. Thrombosis on top of an atherosclerotic plaque. Immediately after the occlusion happens, aerobic metabolism, mitochondrial oxidative phosphorylation, stops. ATP and glycogen reserves deplete. Sodium, calcium, and lactic acid accumulate in the cell, raising the osmolarity of the intracellular fluid, thus causing water to move inside by osmosis. This results in intracellular and mitochondrial edema. Within seconds, the cells are not able to contract. Although these changes are still reversible, if the ischemia continues for more than 20 to 40 minutes, the changes become irreversible. and cell death, necrosis, takes place. Under the microscope, signs of coagulative necrosis will be visible after 4 to 12 hours. The debris that is left behind after the cells die causes an inflammatory response, because all of this debris actually has to be cleaned. It can't just stay in there. In order to clean it, inflammatory cells such as macrophages and neutrophils arrive to the site. This process is most intensive 5 to 10 days after the insult has happened. Within the next 1 to 2 weeks, the place where the necrotic myocytes used to be gets filled by something called granulomatous tissue, which, for a period of time of up to 6 weeks, will continue to become fibrous tissue, aka a form of scarring. Assuming that the patient survives the initial insult, their heart function is never going to return to what it previously used to be. Although the treatment options for myocardial infarction have dramatically improved over the years, the infarction still leaves a permanent mark on all its survivors. They all have to be on long-term medical treatments in order to keep their heart function as close to the optimum as possible and prevent reoccurrences of the insult. With that being said, take care everybody, and remember to make healthy choices. Goodbye.